Good evening, everyone, or maybe good afternoon or good morning, depending on where you're listening to this talk. I understand that there are a good number of people logged on from all around the world. So welcome. Thank you for spending the next hour of your lives with me. I appreciate you listening to this talk, and I'd like to thank Viva Learning for putting this all together. And as well, especially, I would like to thank Purell Pharma for sponsoring this talk. They carry an articaine local anesthetic called Orablock. I'll be talking about articaine in the second part of this lecture, and it'll be quite apparent to you all listening why Purell Pharma is interested in sponsoring a lecture of this topic. So my name is David Eisen. I'm a dentist. I practice in Toronto. I have a practice called Sleep for Dentistry, and we treat mostly patients who require extra care for their dental work, usually with some form of sedation or anesthesia. I do some lecturing as well, as you can plainly see by listening to this talk. And I hope you enjoyed this. This lecture really is one of 5 or 6 that I have sort of in my bag, and I'm updating it continuously. I'm always looking for new research and new products that have to do with local anesthesia, and always adding stuff to this talk. So you'll see some articles, one that was just published about a month ago. So it's about as new as it could possibly be, I think. I hope you find some new things that you hadn't heard of before, and maybe if you're a dentist or a hygienist injecting or using local anesthetics, maybe this will help give you some different ideas with respect to what you do on a day-to-day basis. We'll have a question session at the end. I'm going to go 50 minutes to an hour. With over 1,400 people logged on, I probably won't get to all the questions. And my email address is on this slide. You're welcome to email me anytime if your questions aren't answered at the end. So this talk will have 3 sections to it. The first will be 10 newer devices that are available to the dental marketplace, and new drugs as well. Then we will talk about local anesthetic drugs and sort of combinations that we can use, not just local anesthetics, but other drugs that we can use along with our local anesthetic regimen in order to help the effectiveness of a local anesthetic. And you'll see some very interesting, cool ideas with respect to things that we can do right now to make the local anesthetics work better. And if not right now, maybe in the future, you'll see some research that is being done to change the formula of the local anesthetic to make it work better. And then finally, we'll look at some recent studies, and I will incorporate those studies into your local anesthetic practice, and you'll plainly be able to see how these studies make recommendations with respect to how we use a local anesthetic. So first, let's take a look at computer devices. Now, everything is going by way of computer. Computers are very meldable and adaptable and changeable, and as technology improves and we get better at developing these things, they're getting better as well. And there are 6 or 7 available to the dental marketplace. These are all available in the US. They're not all available in Canada. Some are. And you can see that, you will see that. You can do anything with the, you can make them any shape you want. You can program them to do anything you want. Once you're using a computer now, you have full control with respect to what they look like and what they do. Generally, these things basically have the capability to inject more slowly. And, some recommendations are to do a 4-minute injection in the palate if you are putting a whole cartridge up there. For us to push for 4 minutes isn't really practical, but maybe a computer can do that a little better for us. And with very slow injections, we know that the rate we inject is probably the most important factor with respect to what hurts when we inject a local anesthetic. So these things are programmed to be able to go slowly should we choose that program to inject slowly. And you can make them look nice. You can make them look not shiny and stainless steel or like a needle. And if a kid sees a blue pen instead of a syringe and a needle, he or she may be less fearful of what's about to come. And it looks good. You say to your patients, I've got this computer now. You put it in your newsletter. We're using a computer to give you a local anesthetic. That, I think, is certainly a good marketing tool. But like anything, that there are some downside to using these computer, and that really is all about just getting used to them. Dentists generally, and hygienists too, I would assume, are like the predictable, and we all get used to things a certain way. And even if you change your injection, if you go from a Gaugates to a Gaugates from a inferior alveolar nerve block, the angle is different. You're looking at different landmarks, and this changes what we're used to. We get thousands of injections every year, and so giving an injection is just basically like opening a door. And when you change that to a foot pedal or pressing buttons, holding things like a dart instead of the way we hold a needle and syringe, that takes some getting used to, and we have to give it a chance and let ourselves get used to the whole new routine, the new feel, and then decide if it works for us or not. They're expensive. Some have consumables, so you have to continuously purchase disposable parts. Some use Luraloc needles, but let me show you these just very quickly. And really, I don't know if one is any better than the other, but there is one that I'll show you that I think has some pretty cool advantages to it. So this one, the wand, many of us have heard of this. It's been around for maybe 20 years or so. It's not by any means new, but what this thing can do is it can measure the pressure of the injection while it's occurring. And so, you put this in the palate or in the PDL space. This device knows that it's a dense area, and it's programmed to inject more slowly. So it has a feedback mechanism, which is great. So the slow injection, if you put this on slow, it'll take 4 minutes to push the whole cartridge out. The fast injection is about 1 minute for the full cartridge. And this is, we can hold this like a pen, and it doesn't look like the syringe. And, some people might be a little more comfortable seeing their injection with one of these devices as opposed to the scarier silver needle and syringe. This is a second one. It's called CalEject, very similar to the wand. And it has 3 speeds, one for the palate or PDL, one for infiltration, which would be the intermediate speed, and a fast speed for a block. Again, pressure sensing technology. It aspirates with a foot pedal. And so it's a very similar device, just looks a little different. And this one doesn't have any disposables. This one is by Dental High Tech. It's called the Quick Sleeper. This is pretty popular in France, but it's available in Canada. Pretty sure it's available in the US as well. And the neat thing about this device is it actually can spin. And so you can do an intraosseous injection with this computer-controlled device. It also has a slow and a fast speed. They also sell a handheld device. And now this is getting cool, because here now we're There's nothing on the counter anymore. There's no foot pedals. So this is all controlled by hand. And now we're starting to get into a really sleek device that really looks cool and our patients might find very interesting. To go one step further, this is a handheld device called DentaPen. This one is by Septodont, and you can see how small this is. This is the device in my hand, and it has a ring that you put your finger and thumb on. There are two different positions. It's very light. The only consumable is a sleeve that goes over this. And then the operating part of it, where the controls are, there's a on-off button, there's a activation button that will cause the device to aspirate. There are 3 speeds to this device: slow, medium, and fast. And then there is also something called a ramp up speed, where if you want, in the middle of your injection, you can increase the speed of the device while the injection is occurring. So this is kind of all controlled by your hand, and it's very small and light and easy to maneuver. When we're using these computers, well, why would we want to use these things besides slow, almost painless injections, even in the palate? They're great for PDL injections. If you've ever done a PDL injection, you know how hard it is to push the local anesthetic into the PDL space. It's pretty tough to do. But these computers are great at that. You just basically turn it onto the slow speed, and away you go. There are 2 blocks that are interesting that you can do with a computer or even with a syringe, but this involves putting a full cartridge of local anesthetic into the palate, and you want to do that very slowly, obviously, to avoid tissue necrosis. So the computer, again, does this 3 or 4 minute injection to allow you to put a full cartridge of anesthetic into the palate. So the AMSA block, anterior superior alveolar nerve block, where you would put the local anesthetic right around number 2, so right here, that would give you a block from the second premolar to the central incisor with no soft tissue anesthesia. So that's pretty cool. And you could do, if you're doing veneers, you can do this bilaterally, and that's a nice method to give you good anesthesia, but you've got to put a good amount of anesthetic into the palate. Something called a PASA injection, which is number 3 here. We're putting a full cartridge right near the incisive papilla, and you get a block from cuspid to cuspid. Again, no lip anesthesia in this injection, and a nice way to do anterior dentistry in the maxilla. Another set of devices that are available besides computers are these so-called jet injectors. This is a fantastic idea. So here, these guys don't have any needles. Basically, they are shooting the anesthetic with an extremely high amount of pressure through the gingiva onto the cortex, and then the local anesthetic dissolves through the cortex into the area where the root is. Now, these devices initially weren't for dentistry. They were for vaccinations, for example. That was the one on the bottom right here. This is called the MetaJet, and this was used around the world to give a vaccination. You can't use a dental cartridge with this. So somebody said, well, let's make one with a dental cartridge, and that's this top one on the upper right called the SearJet. You can put a cartridge right here, and you activate the spring. This is spring activated, and sprays a small amount of anesthetic onto the gingiva. A newer one, which is really fantastic, and this is a great device. The only problem is you can't get it anymore because the company that was selling it folded. So this is a jet injector called Injex, and basically it has a system where you put the local anesthetic into their little plastic housing, and then you crank the device and you are able to inject about 0.3 cc's of local anesthetic and you get good pulpal anesthesia. Now, there are downsides with these things. They're not all that reliable. They don't always work. And they're really only limited for maybe only anterior areas because the thickness of the buccal cortex maybe doesn't work on molars. I mean, there's no studies for these things for dental procedures, so it's a bit Wild West. But who knows? Maybe these jet injectors will become more commonplace and we'll see them around. Another new product, this is available in the US, not yet available in Canada. It's called the Ultra Safety Plus. This is a new safety device. This one is sold by Septodont. They sell other syringes that are similar to this. It's fully disposable, except for the thumb ring that is reusable, sterilizable. But everything past the thumb ring, so past this blue thumb ring, cartridge sheath and needle, you slide the sheath over the end of the needle when you're done, and this avoids the requirement of having to recap the needle when you're finished your injection. And we know that needle sticks happen, and in fact, needle stick injuries from the local anesthetic syringe and needle is the most common dental injury from the sharps. So we got to be careful, and maybe one of these devices will reduce the incidence of needle stick. What about intraosseous injections? This isn't new. Maybe you've heard of it before. I like it a lot, and that's why, even though it's not new, but I'm including it in this talk. It's been around for a while. This is called X-Tip. It's sold by Tulsa Dental, which is a part of Dentsply. And this is a device that will allow you to perforate the buccal cortex, and then with their needle, which is the yellow tip here, inject local anesthetic through the cortex. So the way you do this is first you need to anesthetize the tissue and the buccal cortex, and then you take your slow speed handpiece that has the perforator, you peck at the tissue and the bone, so you just kind of push like a woodpecker there. You don't want to do this for too long because it'll heat the area up and cause some necrosis. So if the cortex is too thick, this isn't going to work. But you peck at the bone, and then this perforator will fall in. And then you take a pair of hemostats or cotton plier, hold the disc against the gingiva, pull the slow speed out, and you're left with this target here. And you can take your yellow ultra short needle that they supply with this product, inject half a cartridge into this area, and you'll get good pulpal anesthesia of this premolar and molar. Intraosseous injections don't last as long as an infiltration or a block, so you may have to inject the second cartridge if you're doing or the second half of the cartridge if you're doing a longer procedure. There is a class of local anesthetics called periodontal gels. There's 3 that I know of on the marketplace. I'll show you just one of them because I think it's by far and away a better product. This one is called Orachix. There's also Hurrypack and Cetacane. They are the exact same type of product. Basically, this is a gel that you are going to apply to the sulcus before scaling. This isn't for pulpal anesthesia, so you won't get any root sensitivity improvement, but certainly this product has been shown with studies that you get a significant decrease in pain of the soft tissue when we do deep scaling on a periodontal patient. This is lidocaine and prilocaine. It's a 5% solution. Each local anesthetic is 2.5%. And this is the exact same product as EMLA. But what's really cool about this is that it has something inside of it called a thermosetting agent. And that allows it to thicken when it's applied to the sulcus, and it increases in temperature it goes from room temperature to body temperature, and that's what causes the thermal setting agent to allow it to stay in the sulcus. It doesn't run away or go to other areas of the mouth. You get about a 20-minute duration, so you can certainly do the whole mouth. You're allowed to use 4 cartridges. It comes in a cartridge that's like the local anesthetic cartridge, but it has a little safety collar here. You couldn't put this in your syringe; it wouldn't fit. They come with a proprietary applicator, which you would purchase, and you would squirt this into the sulcus. So it works. Studies have shown this gives you very good soft tissue anesthesia, and our patients appreciate it. But I use this for some other. I just actually used it today. I had a kid come in who had a primary tooth that was almost fully. The roots had almost fully resorbed. It was just about ready to come out, and I took this local anesthetic and just squirted it under the primary tooth, and I was able to extract it without the kid knowing what I was doing. So there's no needle here. This tip isn't a needle; it's just an applicator that you squirt around the area. So I thought of what else could you use this for? Well, sometimes I'll put this over the buccal tissue if I'm putting a rubber dam clamp, and temporary crown removal. I've used it often to remove a submerged healing cap on top of an implant. Gingiva overgrows it. So, just some other ways to use this product. These are all off-label uses. Dentsply, who sells this product, won't allow me to do a lecture and tell you to use that product for these applications. Strictly, this product is designed to be used for scaling periodontal pockets, but it's only a topical anesthetic, so what the heck. So here is the next new product. This is called Auraverse, and this is awesome. I use this at least once a week. It's a antidote for the local anesthetic. It's available, approved in both the US and Canada. And basically, this is like the opposite of epinephrine. So it's a very potent vasodilator. The drug is called phentolamine mesylate. And phentolamine is used in medicine for hypertension emergencies, because it's such a potent vasodilator that it lowers the blood pressure. However, it's not in dentistry. Our uses, the concentration that we are given in the cartridge isn't nearly enough for us to have cardiac worries. We're not going to get any hypotension if we use this properly. It's also used for cocaine overdoses, pheochromocytoma, which is a weird tumor of the adrenal gland. And the very interesting reason this is used is if you use an epinephrine autoinjector and by mistake inject it into your thumb, the epinephrine will cause severe vasoconstriction of the vessels in your thumb, and you could get necrosis. People have had the tip of their thumb necrose and fall off. So this drug is used, phentolamine is used as a vasodilator to open the vessels up and allow the epinephrine to be taken up by the cardiovascular system, and blood flow happens again. So it comes in a cartridge, 0.4 milligrams, and lots of reasons that you want somebody to not be numb when they leave your office. Special needs people, kids, diabetics, so they can eat sooner, people who talk for their profession and are going right back to work. My favorite reason to use this is so I can operate in the lower quadrants, both sides, without the worry of the patient going home with significant tongue and lip anesthesia. So that comes away, that dissipates much more quickly when we use Auraverse. But if you're doing something that hurts, if you're doing a root canal or an extraction, you probably don't want the local anesthetic to offset quickly. You want people to be numb for a period of time so that they have less discomfort 1, 2, even 3 days later. And so you wouldn't want to use this if you're doing a procedure that is particularly painful. The protocol is if you use 1 cartridge of local anesthetic, you would use 1 cartridge of Oraverse. You can do this in kids who are 6 years old. There are new studies now. I think you can even go down to 4-year-olds. So you can do this on kids as well. You wouldn't want to use more than half a cartridge on a child. And literature shows that you get a significant decrease in lip and tongue anesthesia, and so it's a pretty cool thing. The next device or new product that I'll talk about is buffering devices, our buffering devices. And there are 2 approved devices. There's one called Anterior, there's one called Onset. And these devices basically infuse sodium bicarbonate into the local anesthetic cartridge. Well, not the Anterior device, that works differently. I'll show you it. But you can do this yourself with sodium bicarbonate and a 1 cc syringe. You can inject bicarb, I'll show you this in a minute, into your local anesthetic cartridge. And maybe you're thinking to yourself, well, why would I want to do that? And let me explain why. And this, by the way, I think is one area where in the future local anesthetics will be improved. And local anesthetics are very acidic, especially if they have a vasoconstrictor. And acid is bad when it comes to the efficacy of a local anesthetic. Acid makes the local anesthetic work backwards. It doesn't work as well in an acidic environment. So if the local anesthetic were more basic, it would hurt less when we inject it. It would work more quickly. It would work better in areas of infection. And it would be just an overall better local anesthetic product. So this Onset product made by On Pharma comes with 3 ml bicarb cartridges. It comes with a connector and a mixing pan, and the mixing pan allows you to dial in about 0.1 or 0.2 mils of sodium bicarbonate into the local anesthetic cartridge. And this is what it looks like when it's all set up. This is the other device. It's called the Nutra. And this, you need a vial of lidocaine. You can't use a local anesthetic cartridge. And you would, when you put the vial of lidocaine inside the device, you pull back on this blue ring, and that will suck the local anesthetic and the bicarbonate into the syringe. And so you're using a different syringe for your injections. So there's lots of literature that tells us that a more basic local anesthetic will hurt less. This is a meta-analysis that was done by Davis in 2003 for medical injections of local anesthetic medical procedures. And this study showed that buffered local anesthetics hurt less. This is a dental meta-analysis, and this one said that a buffered local anesthetic is going to be 2.29 times more successful than a non-buffered local anesthetic for both mandibular and maxillary teeth. Now, here is a very smart study done by Jason Goodchild, and what he did was he said, well, what happens if we just put the bicarb right into the local anesthetic cartridge? What will happen? So they took 0.1 or 0.2 mils of sodium bicarbonate with a 1 cc syringe and injected it into the 4 different local anesthetics. So the pH is in red here. This is the pH without the sodium bicarb. And then the 0.1 cc injection of bicarb gave us pHs of almost 7. And then the 0.2 cc injection of bicarb gave us even better neutral pHs. And so this is good. I mean, why not do this? Why not use a more basic local anesthetic if it's going to work better, especially in areas of infection? Next new product is called Septaject Evolution. This is a very sharp needle. It's got a scalpel design to it. This is so sharp that it doesn't come in a long 35 millimeter length. So this is only for infiltrations, because you put this past the lingual nerve and it could actually sever the lingual nerve if you use it for an inferior alveolar nerve block. So this is an infiltration needle. And the reason I show you this is because, you want a sharp needle. A sharp needle is going to cause less pain because there's less damage to the tissue when you push it through. There's less resistance. It goes through much more easily. Dental High Tech, the company that had one of those computers that I show you, they have a set of ultra sharp needles. Again, I wouldn't use this for an inferior alveolar nerve block, even though they do have a long 35 millimeter version of this needle. The second last new product that I'll show you is intranasal anesthesia. And here now we're talking really awesome new ideas with respect to delivering local anesthetic. In medicine, it's known to administer a local anesthetic intranasally. Both cocaine and tetracaine are used in medicine. So what about in dentistry? Why would we want to use this? The reason we would want to use this is because the middle and anterior superior alveolar nerve are just behind the nasal cavity. So if you squirt a local anesthetic up there, you block these nerves. Blocking these nerves gives you pulpal anesthesia of the maxillary premolars and maxillary anterior teeth. So if somebody came along and said, well, let's figure out one of these devices for dentistry. Okay, well, let me just go back a sec. But it needs a vasoconstrictor. So our local anesthetics injectables have epinephrine. This one has a vasoconstrictor called oxymetazoline, which has the exact same cardiac profile really as epinephrine. So there is the same small little concern about cardiac stimulation when we use this, no more so than a local anesthetic, but it certainly isn't benign from a cardiac perspective. So we have to keep that in mind. And studies show that it works. You get this study showed 100% pulpal anesthesia for premolars and anterior teeth. So here's a device. It's called Covanase, and it's 6 milligrams of tetracaine with the oxymetazoline. You can use this in kids who weigh more than 40 kilograms. But unfortunately, like that jet injector injects that I showed you, the company has folded. So I don't believe anybody is carrying it right now. I hope it comes back because this is another great way to deliver a local anesthetic. Like anything else, though, it has its downside. Somebody might say, well, I hate anything in my nose. So it may be not for everybody, but for the person who doesn't like a needle or is very sensitive to the infiltration in the anterior buccal area in the maxilla, it hurts. So this is cool. Last new product, this is called liposomal bupivacaine. Not yet evolved for dentistry, but in medicine, this is awesome. This is basically bupivacaine, which is in a lipid chamber, and it's a slow release lipid chamber. So you inject this local anesthetic, slowly releases over 3 days or so. So you get anesthesia, numbness for 2 to 3 days. Now, why would you want that? Well, if somebody's going to be in pain for that period of time, wouldn't it be nice to have this sort of pocket of anesthesia in there that's going to allow the patient to have much less pain? Again, it's not ready for us. There are very few studies for dentistry, and hopefully we will get something like this one day. But we as dentists are one of the biggest prescribers of opioids. And so if we can do this, instead of prescribing an opioid, I think we're doing a whole world of good. All right, part two. This is a series of studies to show what we can use along with the local anesthetic to make the local anesthetic more effective. So this study looked at using an NSAID given an hour before, and would the NSAID change the efficacy of the local anesthetic? So 3 groups. One group got indomethacin, NSAID. One group got 600 milligrams of ibuprofen, another NSAID. Group 3 got a placebo. Again, all 1 hour before an inferior alveolar nerve block. And you can see in green, the ibuprofen and the indomethacin group had a better success of anesthesia when they had this swallowed an hour before compared to the placebo. There is a study that was done to look at all of the different regimens that are in the literature given to a patient in dentistry 1 hour before an injection of local anesthetic, an inferior alveolar nerve block, in the cases of pulpitis. So these are people who need root canals or extractions. So what other things can we have people swallow an hour before we inject them with a local anesthetic to make it work better? So dexamethasone was the best performer in this meta-analysis survey of the literature. It worked great. It was a significant improvement of the local anesthetic when it was taken by the patient an hour before. Toradol, number 2, ketorolac worked very well as well, as did these NSAIDs, and I already mentioned ibuprofen, but at 300 milligrams, ibuprofen did not have any improvement. What about nitrous oxide? Can you use this to make the local anesthetic work better? This study showed that yes, giving somebody nitrous oxide along with local anesthetic, and in this study they used ibuprofen as well at a dose of 10 milligrams per kilogram. What about this regimen? So nitrous oxide plus the NSAID, and the nitrous oxide group had a significant increase in local anesthetic success than not. Another nitrous oxide study, this time on patients who are having extractions or root canals, they tested a mean dose of nitrous oxide of 42% versus just oxygen. And again, the nitrous oxide increased the success of the local anesthetic. So this is obviously some analgesia happening, maybe some dissociation. Who knows why the nitrous oxide is improving the local anesthetic, but it is. And so if you have nitrous oxide in your offices, it might be something that you employ. And then finally, a very recent study showed that nitrous oxide also increases success and decreases pain of an inferior alveolar nerve block in just regular restorative molars, not only ones who needed root canal or extraction. So what else can we add to the local anesthetic? We talked about adding sodium bicarb. Here's a study that looked at adding mannitol to lidocaine. And mannitol is a drug that's used to enhance the ability of a drug to cross the blood-brain barrier. So mannitol is added to different drugs in medicine already. What about in dentistry? Well, it actually works quite well. So if you add mannitol to lidocaine, you get better success. So who knows, maybe one day our local anesthetics will have mannitol in it. And another really interesting study. So there's a drug called dexmedetomidine. You might know it as Precedex. Precedex is used for procedural sedation. It is a sedative. It is it's an anxiolytic, and it has no cardiac effect. So this study looked at putting Precedex with epinephrine, with articaine, and comparing it to articaine with epinephrine. And the articaine Precedex mixture performed equally to the articaine epinephrine mixture. So now you have articaine with Precedex working as well as articaine with epinephrine, and there is zero cardiac effect of the Precedex. So a local anesthetic that works very well without any cardiac stimulation. All right, let's look at some recent studies. I'll show you what's newest in the literature. And a few older ones as well, but just to tie into our topic of local anesthetics, but most of these are pretty new. So this study looked at the usage of local anesthetics around the world, who uses what. And it's interesting that in Europe, most countries use articaine at well over 90%. So this is Germany in red here. So in Germany, 98% of the local anesthetic cartridges that are used are articaine. And that's very similar in many other European countries. It's not so much the same yet in the US. And I don't know why that is, but maybe I'll convince you otherwise if you're not using it now. Of course, lidocaine is used a lot. It's popular. It's been around. Really, it was the first good injectable local anesthetic. It's been around since the 40s. So it's popular, I think, just by how long it's been around for. But why should you use articaine? Let me convince you if you're not using it already. So this study looked at using articaine as an infiltration drug in the mandible. And if you look at this chart here, you can see that articaine as an infiltration drug works really well, 87% efficacy beside a first molar. That's better than some studies showing the efficacy of an inferior alveolar nerve block. So using articaine as an infiltration drug in the mandible, especially for premolars and anterior teeth, is very good. It's very effective, much more so than our other local anesthetics. So let me show you some meta-analysis of this, of why articaine is better, and then we'll talk specifically about why articaine is better. So this meta-analysis, and again, a meta-analysis, I've said a bunch of these already, is a survey of the literature. It takes all of the studies within that topic and collates them and does like an average report of that topic. They have inclusion criteria, and so it's a very powerful way to show data. So this meta-analysis done by Brent showed that articaine is 3.81 times better at providing pulpal anesthesia via infiltration compared to lidocaine. This meta-analysis compared articaine to our other local anesthetics. And again, articaine had a higher probability of success for an inferior alveolar nerve block if you were doing an extraction or a root canal. So 73% efficacy compared to much lower efficacies for the other local anesthetics. This meta-analysis looked at the safety and efficacy of articaine for third molar extractions. So there were 14 studies, there were over 800 extractions. They compared 4% articaine to 2 and 4% lidocaine, 2% bupivacaine, and bupivacaine. They compared onset time, efficacy, duration, and safety. And again, articaine outperformed all of the other local anesthetics in all parameters except for bupivacaine and duration. So, of course, bupivacaine is a very long-acting local anesthetic, and so it had a longer duration than articaine did. But otherwise, articaine basically outperformed all of the other local anesthetics in those parameters. And from a safety perspective, there was no post-op sequela that was any different with articaine compared to the other local anesthetics that were used in these studies. And two more meta-analysis. This one looked at kids 8 to 15 years old, invasive procedures, so extractions or root canals. And again, articaine infiltration was equal in success to an inferior alveolar nerve block with lidocaine. And the final meta-analysis, which was just in the British Journal of Dentistry a couple months ago, and this one compared articaine in these injections. So the injections are on the left, and the increased efficacy is on the right. So articaine injection for an inferior alveolar nerve block with a normal pulp, this meta-analysis at articaine was better by 1.5 times. This meta-analysis did not show an improvement for an inferior alveolar nerve block for symptomatic teeth. There was a 3.01 times increased efficacy of articaine for an infiltration in the mandible, 2.61 for infiltration in the maxilla, and overall for symptomatic teeth, 1.89 times better. And then onset, it was significantly faster, duration significantly longer, and adverse events, no difference. So why is that? What is it about articaine that makes it a more effective local anesthetic? Well, it's not because it's 4%, because if you compare 4% articaine to 4% lidocaine, for example, lidocaine comes as 2%, right? But if you double it to 4%, 4% articaine is still better than 4% lidocaine. So it's not because it's a more concentrated local anesthetic. The reason it's better is because it's a completely different shaped molecule. It has a 5-sided ring called a thiophene ring instead of the 6-sided benzene ring. It's smaller. Apparently, it can, I've never seen it do this, but apparently it can fold and penetrate the bone. So from a shape perspective, it may work better. And from certainly a lipid solubility perspective, it has an extra ester chain and a thiophene ring, which makes the molecule more lipid soluble. Nerves are covered by fat. So if something is more lipid soluble, it's going to get in there more effectively. So these are the reasons why we think articaine is a better local anesthetic. So before I leave the articaine topic, it's available everywhere. If you don't use it, you might try it and see whether or not you find it more effective. Certainly, I really don't do nearly as many inferior alveolar nerve blocks because I'm doing a lot of infiltrations with articaine in the mandible. And this is, I talked about Purell Pharma. This is the local anesthetic that they sell. They have an articaine, and their articaine is called Orablock. Now, what about a few other new studies getting away from articaine? So this was a really cool study which looked at where is the mandibular foramen. The mandibular foramen is that little hole on the ramus that the inferior alveolar nerve goes into. Well, we think it's always in one place, but it's not. It has quite a variable location. It can be from 3 to 14 millimeters above the mandibular occlusal plane, and it can be 9.6 to 25.5 millimeters posterior to the anterior border of the ramus. So there's this huge variability of where the inferior alveolar nerve enters the ramus. And that actually can really make it difficult for us to put the local anesthetic where we want it to be. So if you want to look at an average location of where we might do an injection, try and be about 5 millimeters above the occlusal plane and maybe about 16 millimeters behind the anterior border of the ramus. And that might give you an average spot with respect to where the inferior alveolar nerve enters the ramus. Another anatomical study that was done somewhat recently looked at the anatomy of both the inferior alveolar nerve and the canal that it goes into. And it showed that there are many people who have two inferior alveolar nerves and bifid canals as well. And that, you have two canals, you have two openings, and there are accessory openings on the alveolar ridge on the lingual side. So all of these strange locations for the opportunity of a nerve to enter the bone where we don't think it's going to be. And so we do a standard inferior alveolar nerve block and the patient isn't getting numb. Well, maybe it's because they have this variability in their anatomy, and we inject a little bit higher to account for where the different locations might be, or even doing a little bit of a local anesthetic injection on the alveolar ridge on the lingual side to get those foramen that exist on that side as well. Another new study that was done somewhat recently was one that looked at how safe is a local anesthetic for our pregnant patients. So you probably know or should know that there is no local anesthetic that is called a category A. Category A is the safest category of drug for an injection into a patient. No local anesthetic is category A. The best we get is B, and that is either lidocaine or prilocaine. B means either studies have shown it's safe in animals and no studies in women, or not safe in animals and safe in women. So that's what B means. So this study looked at, this was a very well done study, I think. It was in JADA 4 or 5 years ago. They took 210 pregnant people, all requiring dental work. So different procedures, root canals, extractions, and so on. They only used lidocaine, and injections occurred at all different times of the pregnancy. Some were in the first trimester, some second, some third. And what they did was they compared the pregnancy outcomes of those 210 women to another group, a 794 group of pregnant women who were not exposed to any teratogens. So this 794 group, they didn't fly, they didn't smoke or drink or have any x-rays. They had a completely healthy pregnancy. Was there a difference in the pregnancy outcomes, the health of the baby, the gestational age, the birth weight, and so on? Was there any difference at all in these two groups? And the answer was no. There was zero difference in these two groups. And so it looks like lidocaine is safe in all parts of pregnancy. Now, you want to be careful. I mean, this isn't a license to do routine procedures during the first trimester, but I think that if we have to do a procedure on somebody who's in pain, we can take a little bit of comfort in the fact that lidocaine will be safe. We should make sure we're aspirating carefully. We don't want to do an intravascular injection because that's obviously a very toxic injection, especially for somebody who's pregnant, and that would be toxic to the fetus as well. So aspirating carefully, and we can use lidocaine safely for our pregnant patients, but doing so very carefully. This study looked at the aspiration rate of injection of local anesthetic in the area of an inferior alveolar nerve block. And this study showed that you get a 3.2 to 20% rate of aspiration in the area of the inferior alveolar nerve block. Now, why is that important? Well, an inadvertent intravascular injection is the most common cause for toxicity of local anesthetic. So you know now what the rate of aspiration is. It's much lower in other areas of our injection protocols. The inferior alveolar nerve block is one of the more vascular areas that we inject into, especially lower down in the pterygomandibular triangle area. So a few more studies before I turn it over for questions. This one looked at, if we have somebody who's hard to get numb because they need a root canal, would it help to give them a more volume of local anesthetic? And the answer is yes. But interestingly, that isn't the same answer for healthy teeth. So if your local anesthetic fails after one block and you're doing a restorative procedure on a healthy tooth, it might not necessarily be better to give more local anesthetic. It might be better to do a different approach, like a PDL injection or intraosseous, or trying articaine on the buccal side, but not necessarily doing another inferior alveolar nerve block. However, with inflammation, infection, that's the story is different. Using a second cartridge actually will increase the success of your local anesthetic. And the theory here is that when somebody has infection and inflammation, there are more resistant sodium channels in the nerve. We all have sodium resistant channels that don't allow the local anesthetic through. However, infection and inflammation increases those channels. So if you give more local anesthetic, theoretically, that will cover more of those channels, hopefully, and improve the success. What about pain? What is the most comfortable speed for an injection? Most of us will give a cartridge in 20 seconds, and that is fast. Malamud suggests an injection rate of about 1 mil per minute if you're doing an inferior alveolar nerve block. Studies compared 1 minute versus about a minute and a half, and there was no difference for pain. So a minute is about as painless as you're going to get. It doesn't help to go any slower than a minute. But what's really interesting with respect to the speed of your injection is that if you do a really fast inferior alveolar nerve block, let's say 15 seconds, and that's the third study here on this slide, it's not going to work. If you do it very slowly and you take 60 seconds, you're going to have a higher success rate because the slow injection will keep more of the molecules at your needle tip, which is hopefully where the nerve is. Almost at the end here, a really new idea for doing inferior alveolar nerve blocks is to use ultrasound to guide the needle. Obviously, we have heard about this in medicine. There are lots of different medical invasive procedures where ultrasound is used to guide different probes and needles. In dentistry, this could be done as well. Finally, to summarize, before I take some questions, and by the way, just before I summarize, I'd like to thank Viva Learning for hosting this. Thank Purell Pharma for sponsoring this talk. Thank you all for listening. And I'll summarize, and then I'll turn it over to Trung at Viva Learning, and we'll see if there are any questions. I'll try and answer them. But if I don't get to them, please email me. My email address will be there. So what's in the future? We've seen a lot of studies where NSAIDs and steroids are used along with our local anesthetic regimen, and they work. So there will be other protocols available to us to enhance the efficacy of the local anesthetic, especially in areas of infection. There'll be new formulas. There'll be local anesthetics with different things in them, like mannitol or Precedex or sodium bicarbonate. But we can do the sodium bicarbonate now ourselves by either buying sodium bicarbonate and adding it to the cartridge, or by buying the onset device or the Anterior device. Maybe that slow release formula, that Exparel, the liposomal bupivacaine, will be better for dentistry, and that might help us with pain control after some of our procedures. Maybe there'll be anesthetics that work better in acidic areas because this is where they don't work as well. Or better computer control device. Are we going to have something that's the size of a finger or just the size of the cartridge being able to inject a local anesthetic? Topical anesthetics that penetrate the pulp, better tasting local anesthetics. Or what about a local anesthetic that is specific to pain fibers? So no motor nerve or sensory nerve numbness or blocking, only blocking pain fibers. Maybe that's something that we'll see one day. So thank you for listening. I appreciate your attendance, and we'll see. I'm going to open up the Q&A box, and we'll see if we have any questions. Sorry, I'm just going down here. Okay, so here's a question. Does the study on pregnant women show that lidocaine is safe, including lidocaine with epinephrine? And the answer is you would 100% want to use the epinephrine, because the epinephrine will make the lidocaine safer by decreasing its ability to get into the cardiovascular system. There's some thought that using epinephrine on people who are pregnant isn't good, but I really don't think that is a concern. Certainly, it should be cleared with the medical doctor following the pregnant person. And I've actually heard some obstetricians say that we shouldn't use epinephrine on pregnant people, but that's an old thought. There's really no scientific basis for that. It's important to use it because it will make the local anesthetic safer. So here is a question. There's a few questions about this. Questions, I'll just paraphrase 3 or 4 questions about using articaine for an inferior alveolar nerve block. Does it cause paresthesia? So I could talk about this for 20 minutes. In my lectures, my full day local anesthetic lectures, I talk about this for 20 minutes. So let me give you a short answer as best I can, because it's an important thing to talk about. About 15 years ago, someone did a survey of complaints that were made in Ontario, Canada, to a licensing body, the dental licensing body, of prolonged numbness after dentistry, after inferior alveolar nerve block. And they found that 4% solutions, articaine and prilocaine, were more associated with those events. This was repeated in the same college in Ontario 10 years later. Similar results were found. It was repeated in the US, and as well, it was repeated in Denmark. However, we have to keep in mind that this isn't a scientific study. This is a set of data that is submitted by different people without any scientific control. So there's bias, there are controlling factors that aren't there. And so this is a report. Now I think we have to be mindful of the report, but I think we have to also be mindful that it's not science. And so the newer meta-analysis studies that I showed you show that there are no increased events, untoward events, when articaine is used compared to the other local anesthetics. But we have to, as practitioners, we have to make our own decisions and decide whether or not those reports in the literature, not in the literature, but those reports of not scientific events are useful enough for us not to use articaine as an inferior nerve block, or do we choose it carefully and use it only in certain situations for blocks, maybe not using it for a child, anytime. So I think all local anesthetics could be damaging to a nerve. So maybe we don't use this for a child because their nerves are thinner. Okay, there's way more to talk about with respect to that topic, but that's all I'll say about it right now. So here's a question: what about using carbocaine on pregnant women and people with hypertension? I would say absolutely not. Carbocaine is not a safe local anesthetic for people who are pregnant. It's category C even. It's not even category B. And for people with hypertension, I would stick to a plain local anesthetic like prilocaine plain or carbocaine plain. Yes, carbocaine plain would be good for people with hypertension. Let me find one more question. Sorry, one moment. I think that's it. I think that's all for questions. Oh, sorry, one more. Okay, one last question, and then we'll cut it off. And then please, if I didn't get your question, email me anytime. Would a Gauge block be preferable to an inferior alveolar nerve block for mandibular anesthesia? And actually, a Gauge block is pretty much how I give all of my blocks. Gauge blocks definitely are better from an anatomical perspective because you're going to be above a bifid nerve or a mandibular foramen located in a strange spot, and you have a perceptible endpoint. And I think it is a easier way to do a block of the hemimandible. Okay, I'll end it there. Thank you again for listening, and everyone be well. And hopefully we'll meet one day. Thank you and bye-bye.